Welcome everybody to our webinar called Motivational Interviewing 101. We're going to start today by introducing a little bit about the Maine Health Management Coalition, and then we'll turn it over to our presenter, Dr. Catlett. Couple of housekeeping items. If you have questions, we're asking you to type them in the chat box on your screen, and we'll be holding the questions till the end and then giving them to Dr. Catlett at the end of the webinar. So the chat box at the bottom of your what is that called? Your little screen. We also will be making the slides available for members, and if you signed up on our website, so feel free to do that. And we would love it if you would fill out a survey about this webinar after it's completed. So we take your feedback very seriously and welcome what you have to say. So with that, we'll get started. So the Maine Health Management Coalition is a purchaser-led partnership, and we have multi-stakeholders who work collaboratively. And what we work on is we improve healthcare in Maine. We want to maximize the value of healthcare services for everyone in Maine. And we have over 60 members currently, made up of health plans, brokers, benefit consultants, providers, affiliates, consumers, and purchasers. Our presenter today is Dr. Larry Catlett, who founded the Occupational Medical Consulting LLC in 1996, responding to the increased need for health and wellness workplace solutions. He provides medical oversight and executive direction to OMC's employees who deliver on-site wellness while working to expand development of effective condition management and health promotion programs. He's a member of ACOEM and a certified MRO and FMCSA medical examiner. He serves as a charter member of the MEMIC Medical Advisory Board. He was recognized as a WELCOA Top 10 Health Promotion Professional in 2014. For 20 years, he's been working to change the healthcare paradigm from disease and claim management to disease and claim prevention. He's presented his ideas and experience with wellness interventions through numerous venues. As a family physician, ER doc, and now occupational medicine practitioner, he's seen firsthand the ravages of preventable disease. His passion now is to prevent that disease before it takes its toll, allowing people to stay healthy and do what they love. Now I'm going to turn over the controls to Dr. Catlett. He'll be on in just 1 minute.
Well, welcome everyone. I really appreciate you attending today's webinar. Before we get started, I'd like to be able to review a couple of objectives with you so we have some direction to this talk. I want you at the end to be aware of some of the problems in care compliance. I want you to be able to identify some of the reasons people behave the way they do with regard to noncompliance in healthcare. I'm looking for you to get a hold of the essential elements of motivational interviewing. I wish I could say that you all are going to be experts when the course is over today, but that won't be the case. But hopefully we'll spark enough interest to where you can move forward with your own efforts to try to learn and understand how to use this fascinating tool. And you should remember that the best way to learn this is to do it. You can teach and teach and teach, but you actually have to do it to really get a handle on what's going on. I want you to understand the practical application of motivational interviewing in the health behavior change setting, and particularly in that setting of health coaching, and to realize the possibility of motivational interviewing in non-medical sessions as well. I want to leave you with some understanding of how motivational interviewing coaching can change behavior, decrease risk, and affect spending as well. The motivational interviewing discussion is mostly centered around a book by Miller and Rollnick, R-O-L-L-N-I-C-K, who were published by the Guilford Press. It's the 3rd edition. It's called Motivational Interviewing, Helping People Change, and it would be a great textbook for you. Easy to read, easy to understand, and very instructive. The risk analysis that I'm going to talk about today, or the risk analytical kind of approach, was first put forth by Dr. D. Eddington while he was at the University of Michigan, looking at how certain risk affected health and medical spend. All right, to get started, well, we have problems, and we have more problems. We just don't do what we should. Of 3.8 billion prescriptions each year, half are not taken correctly or at all. A study of 8,400 seniors that were prescribed statins and blood pressure meds, 33% were being done or taken correctly at 6 months. And the bad part was, if you were not compliant with this regimen and high blood pressure was your diagnosis, you had a 5.4-fold increase in hospitalization and death. Just exactly the opposite of what we're trying to do in medicine. After myocardial infarction, only 50% of people are taking their meds. Over 10 years, 3 in 1,000 people are compliant with the FOB-TE-FIT screening for colorectal cancer, which, as you may or may not know, is right up there now in Canada, for instance, is a substitute for doing colonoscopy. It's a very good test, particularly when done over long periods of time, but it's very difficult to get people to follow up. 33% of over 50 people have no colorectal cancer screening at all. Known diabetics only have had their eyes looked at 31% of the time and their kidneys screened 49% of the time. Americans are sedentary, 45%. 35% go 1 time a week, which is better than nothing, but 50% of any new exercises I'm able to move in by conventional means drop out in about 6 months. And only 39% of us eat well. Why do we do this? Well, the first way to understand it, I think, is to look at the concept of mindlessness, the opposite of the popular term now, mindfulness. And basically, I think it's because current behaviors are formulated in some context using certain social constructs along the way, and then they become, by repetition, ingrained, and we stop thinking about why we're doing them, even though the behavior may not be applicable to the particular circumstance we currently are in. The individual may also be very accepting of health dogma, which is a big concern, and labels and procedures of questionable consequence without any evaluation of their validity at all. And they may come in and say, I don't have the wherewithal to do anything about this. My personal resources are limited, even though that may be a total misconstruction. And they don't ask who says so, which is the key to really having success in medical care and making sure you understand what's going on. A big problem is lack of intrinsic motivation. This means that the desired behavior, the behavior we want, is not supported by intrinsic, self-valued reasons for change. People just don't value what we value necessarily as healthcare providers. So what's missing? The compliance health behavior issues that were noted earlier are present because the particular change task, what we're trying to change, the behavior we want to move, is not important to that individual. That is, the reasons, all the education in the world, all the public health information we can pass to people, given to them through whatever source, just don't strike a bell. They don't hit a nerve. They're not emotionally accepted. They're just not something that's important to the person. An example of this, you should stop smoking because it might give you heart disease. That's good. I mean, it's true. But that may not at all register as an emotionally significant issue to them to help promote change at that point because of their current value system and their current context of a recent divorce and job loss. There are just too many more important things that we need to address first. And people have their own good reasons to continue at-risk behavior. This is something from The Little Prince, where he was interviewing a tippler and asked, "Why are you drinking?" demanded the Little Prince. "So that I may forget," replied the tippler. "Forget what?" replied the Little Prince. "Forget that I am ashamed," the tippler confessed. "Ashamed of what?" insisted the Little Prince. "Ashamed of drinking." The Little Prince went away puzzled. These grown-ups are certainly very, very odd. And Dostoevsky, I think, summed this up, this notion of simply educating people about health hazards and telling them how to change is all that's required. He summed it up by saying, where did all the sages get the idea that a man's desires must be normal and virtuous? Why did they imagine that he must inevitably do what is reasonable and profitable? People just don't work that way. So how does motivational interviewing help in this mess? Well, First of all, to have change, you have to be ambivalent. And if you're going to be ambivalent, then there's a possibility that we could actually move you, because motivational interviewing sharpens, then resolves the normal ambivalence that surrounds change. The should I, shouldn't I question is the ambivalence question. Should I change, should I not? We need to move that toward the should side. Now, by evoking the desirability and necessity of that change, supported by the client's own value system, which I keep saying and which is absolutely critically important, using a non-judgmental, collaborative approach, all the while stressing the client's autonomy to ultimately behave as he, she will, may result in some change for us in the future. This is sort of a summary statement that you might read over a few times to really get a grasp of what motivational interviewing is all about. So let's look at it in a little more detail. I want to start with a quote from a client who is a smoker and is being interviewed about whether or not that's something that they might want to change. And this will be the basis for practicing with some tools about how to make this meaningful, this intervention meaningful to this person. They start out by saying, I really enjoy smoking. I look forward to it, in fact. It is just a very pleasurable activity for me. Most of my friends smoke and they are healthy now. Quitting would just seem strange to me. I would miss it. What are our options? How would you respond to that? Do you have something in your mind? What would you say to that person? I'd like for you to all think about what you might say, and then let's evaluate that as we go forward as to how appropriate it might have been. Well, the response options are, do we ignore these statements? Do we counter the arguments? Do we offer the facts about smoking? Do we weigh in with our expertise? Or, and you can tell which way I want you to go, do we focus on understanding what she is saying, trying to understand what reasons she sees as valid are driving her behavior? Because those are the things we have to deal with. Those are the beliefs and the values we have to deal with if we're going to make any change. Our values are irrelevant, completely irrelevant, and nobody really cares. And that's an important thing to remember in motivational interviewing, is you throw out the expertise stuff because nobody really cares what you think. It's what they think and how you can help them move that forward. How might we respond to this smoker in a way that might result in change talk and maybe even in sustained change? Well, let's look at some tools of motivational interviewing that might help us do that. First, however, let's talk about what we don't want to do. We don't want to try to convince the client they have a problem. We don't want to argue for the benefits of change. We don't want to tell the client how to change. And we don't warn them of the consequences of not changing. You may say to that, well, then how in the world do we do anything? Well, hopefully that will become apparent as we move through the counseling session. All of these above techniques increase resistance to change, drive a wedge between the client and the counselor or the coach, and just make it even more hopeless to make any change or along the stages of change in this kind of a situation. So what do we do? Well, first, we have to be mindful and adopt the spirit of MI. We have to go into the interview, the discussion with the person in a collaborative, not confrontational format. We have to evoke from the person. Motivational interviewing very much believes that what is necessary for change is present in the person but needs to be evoked. Maybe not in the typical way, but in some way that we'll look at as we go along. Rather than just giving them simple education, which causes a confrontation denial trap. I don't really want to listen to that. I don't believe it, so I'm not going to listen to anything else you say either. And we have to stress autonomy at all times. Ultimately, as we said before, you behave as she or he will, not as we would have them do it. And we do not try to exert authority over people, because people don't like to be told what to do, as each of you can attest. So, the first set of tools we want to talk about is ORS. You use your ORS to help people get on the road to change. And that stands for using open-ended questions. Closed-ended questions, yes, no answer, don't get you any information. Affirmations are critical, as we need to talk about them. Every time we get a chance to say you did a good job, we need to do that. We need to make a positive atmosphere for the person we're talking to. And the most important of all tools, I think, personally, in motivational interviewing is reflective listening, and I'll talk about that a little more in a minute. And then we use summaries of what we have heard the person say, and this is the key. Not summaries of what we want to hear, we want them to hear, not summaries that we have made up, but summaries that they have said, and they have a difficult time arguing with those summaries because they said them. And so that's really the key. And as you move forward through stages, you summarize information that is directive in that it moves people toward the change side, the should I side, rather than the shouldn't I side. Let me talk briefly about reflective listening while we're here. Reflective listening is an active listening process. The client you're with will think of a thought, they will verbalize that thought, you will hear that thought, and then you put that thought into your brain and let it mill around, and you interpret what you think you heard. And that's what reflective listening is about. There are all kinds of reflective listening statements that you will learn if you decide to go farther on with this. There are simple statements, which are anything but simple, really. There are simple reflections. There are double-sided reflections. There are amplified reflections, all kinds of things that can help you drive a point home. But basically, you're still focusing on what you heard the person say that you think they might mean. And a way to do reflection is when somebody says a statement, sit back a minute and say to yourself, do you mean? And then answer that question. And I'll show you how that works as we go on a little bit into the interview. So ORs, open-ended questions, affirmations, reflective listening, and summaries. And you can follow the rule. Don't try to put forward the writing reflex. Don't try to offer your views and perspectives without permission, and do not argue for them. Understand the client's motivation. We've already talked about how that important it is. We've already talked about how listening is so important. And we need to empower the client, and affirmations can help do that. Be very hopeful about the possibility of change for the person that you're talking to. The hopefulness is what helps people move forward. All right, let's get back to work on our client here for a minute and try a couple of our tools. Let me remind you what our opening statement was. I really enjoy smoking. I look forward to it, in fact. It is just a very pleasurable activity for me. Most of my friends smoke, and they are healthy. Quitting would just seem strange to me. I would miss it. So the health coach who's in the room responds by saying, do you mean quitting is not something you would consider? That's a reflection. It's a simple reflection, but a reflection. The client then responds, because you've said something that probably is pretty close to right. I don't know, maybe not now, but maybe in the future. So this client now has gone from saying, I really would miss it, I don't want to quit, to already talking about change talk just by the use of an applicable, an appropriate reflection. Quitting is not something you would consider. So the health coach goes on and says, why the future? Open-ended question. And the client says, well, there are supposed to be health effects eventually. And the health coach wants a little elaboration on that, another open-ended question. And he says, health effects. And the client says, you know, cancer, lung disease, and stuff. And whenever you see a word like stuff come into the process, you want to pay attention to it, because that's usually where the culprit is hiding. So this health coach had enough sense to say stuff. And the client says, you know, heart disease. And then the health coach, which from experience, says, so heart disease concerns you the most. That's another reflection. It may be a little bit amplified, but it's a reflection that's taking us down the path. And it does indeed move us forward, because then the client says, my mother almost died from a heart attack at 55, and she smoked a pack a day for years. I do not want that to happen to me. The health coach says, you're actually very concerned about smoking and your health. So we're in a very different place than we were when we started by using these reflections and listening to that statement, the opening statement, or the statement above, where the client says, I do not want that to happen to me, which lets us to say freely and probably correctly, you're actually very concerned about smoking and your health. The client then says, I guess, but I don't know, here comes the ambivalence, how I would handle my stress if I quit. Now this is something that's very important. We've now got a clue that stress is a problem here, and that trying to stop people from smoking in a stressful situation is probably the biggest waste of time anybody's ever done. So we want to know a little bit more of that, and the client goes on and says that first deep draw on a cigarette, you can almost see her with her eyes closed, leaning back, just lets me relax and escape for a while. And the health coach says, has to change tact a little bit, but reflect what's been said. You need to smoke to help control your stress, even though you're concerned that it might seriously affect your health. That's a double-sided reflection. where you've agreed and told the client you understand you need to smoke to help control your stress, even though you're concerned that it might seriously affect your health. And so that's the statement of ambivalence that we're working with here. What have we done so far? Now let's look at our progress to date. Well, we didn't use the writing reflex. We didn't try to convince people that they should do what we think they should do. We identified the ambivalence pretty clearly. We've actively listened to and reflected what we thought our client said. We've used brief, open-ended questions to move the conversation along and elaborate client statements for better understanding, and we're on the way to understanding client motivation for smoking. If we do not understand that, we cannot provide alternate motivation. That's a critical factor that we need to understand. So let's go a little farther then. The health coach responds to the final statement previously and says, you smoke to help control your stress and maintain your social contact, because remember, her friends smoked and it was quite a social thing for them to do. The client then says, that's true. In my circle of friends, we almost all smoke. The health coach then says, social ties are more important than your health. Now, this is taking a little bit of a chance, leaping out on a limb, because you're not really sure that's positive, but we need to try to see what kind of response we get. Social ties are more important than your health. And the client responds, I guess I need new friends. This is so hard. Still reflecting the ambivalence, but still talking about change talk. With, I guess I need new friends. The health coach then says in reflection, quitting smoking makes sense to you, but it has its downside. The client says it does, but the more I talk about this, the more I realize I don't want to repeat my mother's experience. The health coach then says your mother's experience is really concerning to you, and the client says, gives us more information. She is on oxygen, her heart is failing, and she can't really do anything now at age 58. That is really scary. How much of this information do you think you'd have got if you said, you know, you really should stop smoking because it causes heart disease and cancer, and it's bad for your health in general? Probably not very much, but we've been able to get almost everything we need to know, or the client actually needs to know and recognize to go forward with a change. And she says, that is really scary. The health coach then says, by quitting smoking, you may be able to keep this serious health problem from happening to you. The client says, yes, I need to figure out how to do this. And the health coach, in affirmation and with hope, says, you can and will. Where should we start? So we know a lot more about this person than when we started. We understand her current motivation to smoke. We continued reflective listening, looking for change talk, which occurred. We affirmed this person, and we are evoking and collaborating, resolving ambivalence, and listening change talk. Now, what do we need to do from here? Well, first, we need to recognize that we have this client telling us why it's important for her to quit smoking. Those things we need to file away and keep a hold of because we're going to need them in the future. She did not consciously recognize this at the start of the encounter. We may continue enhancing importance by looking for other reasons to quit, such as cost, social stigma. Now, she smokes for social reasons, but social stigma apart from her friends may be a problem for her when she goes elsewhere. People walk around her when she smokes. And other undesirable issues about smoking. Before you start a quit plan, we'll probably have to look into those things. And we would need to explore her stress and guide toward goals and targets for better stress management, which I think is a priority for this session, because finalizing a quit plan without having dealt with stress or having alternate ways to deal with stress is not such a good idea. The quit plan could actually come in a later session once the client is comfortable with new stress management tools. We'll also have to deal with the social issues as well. One way we can do that is by looking at well-being in general and looking at the elements of well-being, of which social is one, testing for that and finding ways that we can put forth a plan that will help someone work forward. But we do need to remember we have to attend to people's well-being in general before we try to stop a habit which they use for obvious reasons, in this case managing stress and for social acceptance. Now, by following the basic tenets of MI, we've gone from pre-contemplative in Prochaska's stage of change to preparing. And that's a great thing if we can do that in as little time as we've spent on this person so far. And I think it's quite a feat for 5 to 10 minutes of intervention. So we used our ORs, particularly reflective listening I focused on a lot in this, and you can reread it and look at those reflections and try to understand them, and how we could elicit them by asking, do you mean, when the client has made a statement. Now, The question is, how good is MI in a non-medical setting, or can it work in the non-medical setting? Because MI is not just a counseling technique. It's not just a health counseling technique. It was actually developed by Miller and Rolnick for use in drug abusers because they were using the confrontational techniques of the past and had no success. So they looked at talking to people on a personal, collaborative, evocative, and not authoritarian way, and things came out so much better for them that now it's used all over the place. It's used in medical settings, non-medical settings, legal settings, jail settings, all kinds of places. It really is quite a tool for use. So let's look at it as a collaboration between an HR person and a team member at a particular institution. Now, this team member has had a problem with being late for a long time, and it's become the HR person's lot to deal with it. And so there are lots of ways to deal with it. I think you can imagine some you might use, and let's look at perhaps what might be an alternative, a little different one that might help in the future. The human resource person says, well, thanks for coming in. Any idea why I wanted to talk to you today? A team member says, well, probably because I'm late all the time. And then we have a reflection that the human resource person says, being late is a concern for you. Now that may be, she didn't really say that, but this is a do you mean, and one of the things that she might mean by saying probably because I'm late all the time is that being late is a concern for her. And the team member says, I guess, I'm just so distracted in the morning. We're getting a little more information now as we go along. And to enhance that, HR says distracted. That's like asking, can you elaborate on why you're distracted? And the team member says, I have a hard time getting myself, my husband, and the kids ready. I try giving myself the extra time but still wind up late. Well, so far that's a common reason. A lot of people have problems with late, so we haven't learned anything totally different or new, but we're moving forward in the conversation. So then we say, you've given it a good try anyway. And the team member says, not good enough, I guess. And that affirms that she's probably concerned about being late. HR says being late is something you'd like to fix. And the TM says, absolutely. HR says, why is it important to you? And the TM sits back and reflects a minute and says, well, I don't want to lose my job, and I worry about what my coworkers think. I don't want them to think I'm sloughing off my work to them. So you're having a positive experience with this person so far, and finding out some interesting things, and we'll may find out some other things as we go along. HR then says, any other reasons? And the team member says, well, no, except I would just feel better if I were not so overwhelmed. And HR says, being late is just part of a bigger problem. That's another one of the do you means. It's a great example of a reflection where the team member has said, well, no, except I would just feel better if I were not so overwhelmed. And HR figures out that being late is just a part of a bigger problem. And the TM, now becoming teary, says, I'm just so down. I don't have any energy. I just can't get the work done to get ready in the mornings. And HR says, too much stress right now, as another do you mean. And in fact, the TM says, we are close to losing the house, and one of our kids has a serious medical problem that is taking time and money we do not have. I just don't know what to do, but I need to do something. Can you help? The HR says, you think it's time to fix this. May I make a suggestion? And this is important in motivational interviewing. It is always important to ask, deliver, and ask again. So if you're giving people information, factual information, or you're making suggestions that they might try, you always ask permission to make that suggestion so that the person doesn't take it as a negative and rebel from it rather than respond to it. And once may I make the suggestion and the team member says okay, then you say, you seem at your wit's end, worrying about being late as a result of too much stress. Have you thought about trying our EAP? I can help you make the call. What do you think of that? And so that gives you a use of MI in something that's totally non-medical and purely about stress, and it might have a much more positive ending and forward moving for the client or for the TM than some forms of dealing with this problem. Now I want to ask you, if you got it, I'm going to ask you these questions, and you can sort of read them on the screen, I guess. And then I want you to, in your head, tell me whether they were true or false. And we'll go to the next page and see how you did. While using MI, we avoid arguing with clients. True or false? In using MI, how you say something is as important as what you say. Resolving ambivalence, the should I, shouldn't I question, is the central aim of MI. Directing is a key part of MI. True and false, reflective listening is essential to MI. All right, you got those down? Everybody got their answers correct? We'll move on and see. Whoops, look at that. Every one of them is true. While using MI, we avoid arguing with clients. Arguing engenders resistance. And resistance is the thing we need to overcome if we're going to make any change. So adding to it by arguing is not a good tool. In using MI, how you say something is important as what you say. Remember, we talked about the spirit of MI. You can say something to people in these reflections that if you say it in a negative or a smirky tone can turn the entire encounter off. But if you say it in a I really have your best interest at heart tone, then almost anything you say will be accepted or rejected reasonably by the client, and they will talk to you about how you can correct your perception. So basically, it's the manner in which you say it that's critical. Resolving ambivalence is the central aim of MI. Absolutely, it's a normal and critical part of the change process. We've got to get that should I, shouldn't I question answered before we can move on to could I, can I, can't I, which is how well I can perform. Can I really have the confidence to make change? So importance and confidence is critical in MI. Directing is a key part of MI. I didn't talk a lot about this, but in some of the reflections we used, you will notice that I was trying to take the person in a particular direction, even though I was basing my direction on what they told me, not what I think, not where I want them to go, but what they told me. So directing is a key part. MI is both a client-centered, which means that people sit back. The therapist would sit back, for example, in client-centered therapy and listen to what the person had to say and really not respond. Just wait till the person got themselves on track and could talk themselves into changing. Well, we haven't got that kind of time, so what we really need to do is direct people, but we do it the same way. We sit back and listen, but when they start on a particular path, we help guide them down that path, which has some degree of directing in it. Directing can be too strong, and you have to be cautioned in its use because you may start telling people what to do. But if you just suggest what people will do in your directing and guide them, that would work fine. Reflective listening, I hope I've made that point, is absolutely essential to MI. Without it, it cannot be done. So basically, when somebody says something to you, you can sit back and say, what does that person mean? Do you mean? And give a reflection. You can practice it at home tonight, for example. Now, the last topic I want to cover is, does MI really change at-risk health behavior? Can it reduce risks? And does it have impact on spend? So we'll spend the last little while on this before we go to questions. This is the D. Eddington part I talked about. Through the use of about 2 million or more HRAs, health risk appraisals, over time, Eddington was able to establish what risks cost the most money or wind up in the most spend and consequently make people the most miserable. What are those risks, and what are the levels of risk that really make a difference in people's actual health and healthcare spend? The risks you see listed on the screen are some that he found were the most important issues, and they're scored at 1 point apiece. Now, that may be counterintuitive to some of you. You might think that smoking should definitely be a 5 and that negative health perception could be a 1, but it doesn't turn out that way. It turns out that what really matters is not the individual risks, but a combination of risks which synergistically affects people's health and well-being. What I did was to look and use, is to take Eddington's data and use a health risk appraisal that includes assessing all these risks. And I will tell you that, for one, low back pain is added to this list because so many people have so much trouble with that. And we have to do that on occasion once we survey companies about what their big problems are. Add a list because it is a high cost, high risk for people. But anyway, what we find out is that low risk is 0 to 2 risk. So there's about a baseline that you can't do much better. You're going to spend that much money on health care, and you're going to have a minor degree of suffering at that risk level, or morbidity, as we call it, but it's not nearly as bad as medium, which may spend up to 50% more than low-risk people, or baseline spending, and have more associated morbidity or suffering. Now, when I say suffering, I don't mean necessarily pain, but you're taking medicines that have weird side effects. You're spending the money on the medicine. You're not able to do certain things you'd like to do because of certain problems you have. So there's all kinds of ways that you can express morbidity, and that's really sort of what we're talking about with the medium-risk people. But high risk now may spend 150 to 300% more per year, which means they must be suffering about 150 to 300% more each year. So we have low, medium, and high risk, and the goal would be, obviously, to reduce high and increase low, right? Because that's where you'd like to see everyone suffer less and spend less. And so what we try to do is to develop a process by which that would happen, and this is where MI came in. Now, this is a critical slide. I think it's really important for you to understand this slide. The green box says the higher the risk level, the higher the incidence of disease. Look over at the less than 45 and see that the blue box, which is low risk, okay, medium risk is yellow and red is high. The blue has a 3% incidence of disease in less than 45 at low risk. But at high risk, it has a 25% incidence of disease. 1 in 4 have some sort of chronic disease. If you look at the common age, working age group, 45 to 64, if you're in low risk, 10% of people may develop a disease process, but 56% develop it if you're in high. So we really have to address that high risk, and we have to address low risk people to make sure we keep them where they are. And you don't even want to look at what happens at greater than 65 because 80% of people at high risk have some sort of chronic disease. But this is a point that you should take away with you. It's not age, it's behavior. Because 18%, because there's only an 18% incidence of disease in people greater than 65 that are at low risk. So it's not necessarily age, it's behaviors that change over time because you get used to them, you don't think about them, you're mindlessly performing them, such as your eating habits and your snacking habits, et cetera, your non-exercise habits, and you just don't really have a chance to reduce your risk of getting all these problems. So higher the risk level, the higher the incidence of disease. Higher risk level turns into high cost. The higher the risk level, the greater the cost. These numbers are old from Eddington in 2009, but their relativeness to each other still exists. And if you see that low risk spend the least and high risk spend a lot of excess cash. They spend the low risk plus 3,000 more. So what we obviously want to do is move people down into low risk so we don't have that kind of process going on. Now the question is, can you change the cost risk level? Can you take a higher, medium, low risk level and actually do something about it? Well, if you look at this slide, there's 3 companies on here, company A, B, and C, different sizes, big one up at the top, smaller ones at the bottom, but they all have the same experience. If you look at the green bars over to the right for all 3 companies, the first green bar is lower than the second green bar, meaning that over time, low risk has increased, and exactly the opposite has occurred for high risk. If you look at the red bars on the far right of the side, you'll see that high risk has decreased in every case. And that's the case you want, and that's the association we have with that is health coaching using motivational interviewing. Motivational interviewing helps people make up their mind to make a change, which can change their risk level. So that's, I think, a pretty good demonstration of risk levels can certainly be changed. Then we also want to ask ourselves, do we get enough people involved to have that make a difference? And this is an example of a company of about 1,000, 1,100 people, participants, and basically you see that 87% of employees in the medical plan are participating in the program, and only 13% are not. And 60% of spouses were participating in the program, and only 40% are not. And while that's not as neat a looking graph, pie graph as the one on the left, it's much more meaningful because it's very, very difficult, as those of you know who've ever tried, to get spouses engaged and involved in a wellness program because they're somewhere else. And they have other obligations that need to be done. We can't do it during their day like we can with employees that we coach. But participation is critical, as Eddington said. He needs to have 70 or 80% in participation, 70% at low risk. Well, so we've got the participation numbers. How about the risk? Well, the current cost risk profile in this company in the employees is 2% high risk and 78% low risk. Not much more you can ask than that. because that's enough to make a difference. Remember that only about 70% or so of cost is related to lifestyle change, which is what health behavior change is all about, and health behavior change coaching using motivational interviewing. And so we need to get as many people as we can in a program to have a significant impact on that 70% number. The cost risk profile of the spouses, 1% in high risk, 82% in low risk. This is after several years. And continued motivational interviewing coaching that focuses on keeping people at low risk and reducing people in high risk. And you can see what's happened to the cost risk, those risks we talked about with Eddington, that Eddington devised or determined. And the cost risk, low risk has gone up, and the other two, medium and low, have both gone down over time from a period of 2001 to 2015. This is a little bit different, but basically what this shows is the decreased participant spend over time by reducing the high-risk segment and increasing the low-risk segment of the population. And you can see that that this is all dependent on how much people spend in those categories, and most of the time, high-risk people spend a lot of money, which shows most of the time you see quite a substantial decrease in spend. Occasionally, high-risk don't spend any money, which is actually also good, but it doesn't show you the decrease in spend as well. It's the formula that I devised was made to look at the decrease in high-risk spend. In 2014, I couldn't really talk about spend because the group had grown so small that any catastrophic claim within the high-risk group would skew it dramatically. So just suffice it to say that people had a very low risk level and that most of the people by far were in low risk and very few in high. We look at this graph, we look over in the blue box here, we see for the plan year of 2015, this is a different company altogether now, about the same size. So a couple of interesting points. That the average healthcare spend by participants in this wellness program for over about 5 years was $4,197, while the average healthcare spend of employees not in the wellness program was $13,159. So that makes me think pretty quickly I want to drive everybody I can into a wellness program, because just being in there you're going to average spending less money. And it's not because the bad guys were all outside of the wellness program, because this company experienced significant change in its high and low risk. You can see on the graph here that when they started, their high risk was 26%, now it's 16%. Their low risk was 31%, and now it's 48%. That led to a difference in spend, a calculated spend, compared to what would have been spent by the group if the risk levels hadn't changed, to over $700,000. So that's a very significant amount, and you can see that indeed high-risk people spent $8,441, low-risk people spent $2,932, a substantial difference. So if we can keep the spend at these levels, which over time it averages that high-risk people usually spend more and low-risk spend less, then you're going to see an effect on at least slowing the bottom line. Now, people will always say, well, but doesn't that turn the curve in the opposite direction? Doesn't it stop healthcare spend increases? Wellness has no control over what people charge for health care, none at all. All they can do is reduce demand. So if costs keep going up, as they are, I had an experience yesterday where I had to choose between an MRI for $1,875 or one for $700. Guess which one I chose? And basically for one of somebody we needed to have tested. Basically, that kind of difference makes it hard for wellness programs to actually reverse the trend. But the point is actually if we can slow the trend, we've done well. And you can see that could be the case with repeated changes in that previous graph I showed you with the numbers over time. Finally, I want to end on an existing medical condition risk incidence. One of the worst risks that we have, and we consider it a risk in our particular analysis, is that metabolic syndrome, which is, as you know, a cluster of issues around sugar, waist circumference, blood pressure, glucose, and cholesterol, etc. We were able to reduce that metabolic syndrome from 144 to 90 in this company over a period of about 5 years, a decrease of 38%. And recall that if you have 4 or more of the 5 components of metabolic syndrome, you are guaranteed diabetes development and pretty close to heart disease development. So it's a really important thing to be able to work on it. So behavior change can occur, does occur, and is spurred by motivational interviewing in a one-on-one coach setting. Now I guess we're ready for any questions that you might have.
Well, that was just wonderful, Dr. Catlett, and I think all of us have been in a position where we thought if we just say the information in the right way with the right finesse that it will change the person in front of us, and it never does. If we just word it right. So this was such a good reminder, and for some people, new information about that. I want to remind folks that if you have questions, to type them please in the chat box now. I did get some in, so we'll start with those, but I'll be watching for more as they come in. The first one is, do you think it's advisable to dive in and try motivational interviewing with just this much knowledge?
You know, that's a difficult question. My basic answer would be no, that you need to move a little bit forward and make sure you have a grasp of the basic tools before you do. But I do believe that you can self-teach yourself that pretty well. The books that are available are excellent. There are a couple of other smaller paperbacks that you can use as well. So you can teach yourself pretty quickly. On the other hand, I need to say that some people are intuitive motivational interviewers. The way we discovered this process actually was two things actually happened. The first was we did a pilot at one of the companies that I work for, and we had a nurse come over and review HRAs with people and talk about making plans and talk about taking small steps toward change. And that worked so incredibly well that I had to go sit down and look over what it was that she was actually doing. In the meantime, I met a professor from the University of Maine in Farmington who came to the office and taught us all about motivational interviewing, and was surprised to find and delighted to find that this nurse that I'm talking about on the pilot was actually an intuitive motivational interviewer. She was already doing all the things we talked about, or almost all of them, and was able to help people make change. So part of it depends on who you are, and that's hard to summarize it. A lot of it will depend on, as you read this, how it seems to jump up off the page and say, man, this makes sense to me, then you're probably going to do pretty well with it. And I do think that if you go into this with the spirit of motivational interviewing as a collaboration, as a way to look at people for who they are and accept them for who they are and not try to boss them around, that you have a good chance of coming to some ground where you can help the change process start or set goals to do. I would advise some further study, but again, I hate to see you avoid using it based on fear.
That makes sense. And it actually leads into the second question, which is, other than reading, if I want to learn more and practice more, are there options here in Maine?
Yes, there are more than one training group in Maine. We train people in motivational interviewing. We have a course that we provide for our coaches and for other coaches as part of our business model that we have, that's approved by the Maine Medical Association for 24 credit hours for physicians. So we have a pretty good course ourselves, but there are other people as well, and I think you can just go online and look up resources for that in your area as well.
That's great. This question says, what's an example of a behavior change that you saw personally using MI that was particularly dramatic?
I think the most dramatic thing I saw, the most dramatic thing I've seen motivational interviewing do was all about how a coach handled a particular problem. I was observing this coach for quality assurance, and it was his actually first coaching session, not his first client, but first coaching session, the first day, and he had been trained in motivational interviewing about 2 weeks or so, and which helps answer back to question 1 again, where he sat down with a person who was arms were crossed. He was sitting back in his chair. He's about 50 years old, and he sat back and he looked at the coach, and the coach asked him, well, what do you think about the wellness program and thinking about making behavior change? He says, well, I think it's all great. I think that it's great for the boss to do this for us. I don't think I need it. I eat right. I exercise. I'm not overweight. I smoke, but my grandfather smoked till he was 85, and I'm fine. And the challenge that coach, it was similar to the challenge I gave you in the presentation, where the coach had to figure out what is the appropriate response to that question. And what the coach said was, the coach said, wow, you're doing some good things for your health. And the guy's arms unfolded, he leaned forward, he about fell out of his chair and said, but I smoke. And they went on through that category to get him on a smoking process, and that has been a non-smoking process. And that's been, I think, the biggest, most dramatic change I've seen. It was so quick and so effective because of what the coach reflected. Because it's true. He was eating well. He was not overweight. He exercised regularly. He's doing great things for his health. And so that kind of reflection, that kind of motivational interviewing intervention can lead to dramatic changes quickly.
That's impressive. This question is about hope, which you talked about earlier in the webinar, and it is asking more about how do you instill hope in someone that might not have it.
Well, I'll give you one example. The most hopeless people I see are overweight people or obese people, because they've all tried 1,000 times to lose weight. They've all been unsuccessful. In fact, they've all gained more weight back than they lost, and that is a hopeless situation. However, when you get them to mindfully think about the whole point and get them to get off the BMI numbers and get away from what it is that the CDC suggests you ought to weigh to be a healthy person, and get them to realize that a very slight weight loss of as little as 5%, which is a sustainable possible change and not hopeless at all, can due to their cholesterol, blood pressure, and glucose, then, not to mention their glucose responsiveness, then people become much less hopeless. I think when you try to take people down paths that are just too enormous, almost everything you do in MI leads to a goal and targets which are doable for the person, which they are hopeful they can accomplish. And I think that's really probably the best way to answer that, is that you never try to get people to work toward goals or get suckered into the fact that people say, I'm ready to quit smoking and lose 20 pounds right now. Let's get started. Give me a plan. You have to be careful about that, because they're going to fail. They're going to come back and be harder to get started the next time. So just making a plan that's realistic for the person, that's based on their concerns, what they really care about, and that is reasonable and doable and relatively painless is really the way to instill hope into people the best way, I think.
So it's more than saying, I know you can do it, and being a cheerleader. It's really giving baby steps to people that are achievable.
Hopeful is not cheerleading. It's not the same thing. Hopeful is doing what you need to do through motivational interviewing, which is enhance importance to the change, answer the should I, shouldn't I question, answer the can't I question, which I didn't talk about much, but it's the basic question of building a plan that has targets toward that plan, long-term goal, which are achievable and doable and people are excited about.
That makes sense. And the last question that we have is an interesting one. Did you ever encounter someone who simply showed no ambivalence?
Oh yeah, that you'll find that. And one of the things that we teach the coaches is that at some point in time, you can convert. We call those pre-contemplative people. They're at the beginning stage of change. They haven't even thought about making a change yet. Not within the next year anyway. It's not even on their radar. You can work with those people, but basically what you look for is if they're doing something well already, you emphasize the importance of keeping that up, is to make that, to do a lot of affirmation, to talk about how positive that is, and keeping it up, because you're probably not going to change much else at this point in time. People can change over time and be ready to go, and you look at them again in 6 months and say, well, where are we now in terms of this? I'm just absolutely not ambivalent. I'm not thinking of making change at all. And if you do, sometimes you have to call a spade, and you say, it looks to me like we're not talking about a should I, shouldn't I question here at all. There's no question in your mind you're not interested in changing any of these particular 1, 2, 3, 4, 5, 6 behaviors. And they'll say, yep, that's what I think. And if that's the case, after you've tried to get in them a little bit, then you just have to call a spade and go to work, spend your time somewhere else, come back to them later.
So it isn't always the skill of the motivational interviewer. Sometimes it's just a roadblock.
No, sometimes it's a roadblock that can't be overcome. Many times, the skills of motivational interviewing, when you get really good at it, like if you could see Miller do reflections, mean, he can take somebody from point A to point Z with doing nothing but reflections. If you can see that, how that's done, then you can realize that even the tough ones can change. And I've had people who come up and say, the coach will open up and say, well, here's your list of concerns. What would you like to work on today? And they go, yep. And a smart coach then doesn't go, well, I guess we're not going to get anywhere with this guy. I'll go somewhere else. They say, it sounds like none of these risks are important to you. And they think about that for a minute, and then the coach says, or the guy may say, well, you wouldn't be concerned about your blood pressure either if you were getting a divorce. So now we're in a whole other ballpark. So the skills of motivational interviewing can take you places where you could never dream of going before.
Yes. Yeah. Well, that's it for our questions that we have for today. Do you have any last comments you want to make in summary?
No, I just hope that, I really hope you'll fill out your critique forms and let me know if I got you anywhere toward understanding of MI or not, because I want to make sure I do this as good as I can. And that I don't want you to be scared of trying it. Learn a little more, take a course, and it's amazing what you can do with it. And remember, all the courses you take are never going to get you right. You're not going to go out perfect. You're going to have to try it out on people, because they always have a new twist or tie, and that's listening to people, listening to what they tell you is what's going to make you learn how to do this well.
That's great. I want to thank you so much for your time and presentation. That was terrific. And I'll piggyback on what you said and remind people to please fill out the survey that will be coming to them. We take your feedback very seriously. And that's it for today. Thank you very much.